I would like to now invite Dr. Edward Torpedo, Professor and Associate Dean for Research at LSU School of Public Health, who will introduce the speakers for our next two sessions and will moderate the panel discussion at the end.
Good morning or good afternoon. It's wonderful to be here and to see a lot of friends. It is not such lovely weather in Louisiana for the second time in 10 days or so. And as we see more and more rain cropping up and waiting for more floods. At any rate, the first session speakers are the first one is Dr. Rogelio Sanz, who's going to be talking on the overview of the landscape of changing demographics and trends in Hispanic populations. He will be followed by Dr. Mariana Carla Stern, who's going to be talking about an overview of cancer-related burden in Hispanic populations. And then Dr. Alice Popejoy, who's going to be talking on who is considered Hispanic, applying novel approaches on data collection for future research. And with that, Dr. Sands, if you'd like to start.
Okay. Okay, good morning, everyone, or good afternoon. And it's a pleasure to be here today to talk about the changing demography of the Latino population. So a little bit on, let's see. Here we go. So the outline, I'll provide some brief introductory remarks, talk about the Latino demographic trends over the last 4 or 5 decades, talk about some of the significant changes that are taking place in the demography of Latinos, and then briefly highlight the implications of the changing demography of Latinos on the demography of cancer and some concluding remarks. So over the last 4 or 5 decades, we've seen that Latinos have been the primary driver of the demography of the United States. And we've seen in many respects, the United States would be much more similar to European countries with aging populations, but we've seen really a dynamic Latino population that has continued to provide some influence on the growth of the US population as a whole. And throughout the 21st century, Latinos have accounted for about 1 out of every 2 people that have been added to the nation's population. And this has been attributed to the youthfulness of the Latino population alongside an aging white population that is responsible for some of the major demographic shifts that we've seen and that were aptly captured in the 2020 census. Yet overall in the United States, as the 2020 census revealed, we've seen overall aging of the population and the slowdown of the population growth, and particularly with the white population at the national level that we've seen a decline in the population. And then we've also seen the major demographic shifts in the Latino population that suggest that there are going to be major implications for the changing demography of cancer. So let me talk about the Latino demographic trends over the last half century, the last 5 decades. And here's a graph that shows you the Latino population size, and you can see tremendous changes over this half century that we're seeing more of a quadrupling of the population from 1980 to 2020. And from the start of the 21st century in 2000, we've seen about a 76% growth in the Latino population during that time. So what we see, what has been responsible for this demographic shifts have been the different age structure of the Latino population and the white population. And here you can see, for example, with the Latino population, we're talking about 31%, almost a third of the Latino population being less than 18 years of age, compared to 19% for the white population. On the other hand, where we're talking about 65 and older, whites are 21% versus about 8% for the Latino population. And we can see a child to elderly ratio of 4 in the Latino community compared to 9 0.9 for the white population. And then you can see the tremendously different median ages, also about 30 compared to 43 to 44. And demographers talk about use the age sex pyramids to illustrate how youthful or how old the population is. And you can see the tremendous difference where you see a broader base in the Latino population, indicating more children in the population. And then with the white population, you see bars that are much larger towards the older ages, it's signifying again very much influenced by the aging of baby boomers that is taking place. So at the Latino population, you see kind of a needle towards the top and much greater size bars for the white population. Here, so one of the things that we've seen has been a significant change in the demography of the Latino population. The Latino population continues to grow at a fast pace, but we've seen that there has been a slowdown. So this is, you can see here, for example, a much faster growth that was taking place in the Latino population at an earlier point in time. We're talking about upwards of 50% in the 1980 to 1990, 1990 to 2000. And then all of a sudden, what we've seen is a slowdown. So over the last decade, between 2010 and 2020, a 23% increase in the Latino population. And this has to do with two significant trends that we've seen. One has been a significant decline in fertility. So we've seen during the economic recession from 2008 to the present, significant drops in fertility, but particularly among Latina women. Back in about 2008 or so, Latina women were having on average about 2.8, 2.9 births per woman, and now that's down to about 1.9 or so. And then the other major area where we've seen a significant change in the demography of Latinos has been with respect to immigration. With immigration, we've seen a major slowdown, but particularly from immigration from Mexico, that the flows of immigrants that we were seeing during the early parts of the 21st century compared to today, now we're about less than half the level that we had the immigration flows that we were witnessing back at the start of the 21st century. So this has really brought about that significant slowdown in the population. But because the white population in particular is aging quite significantly, what we see is that Latinos continue to play a significant role in the change in the U.S. population. One of the things that we'll also see is that because of the growth that was taking place, significant growth in the Latino population, and as Eliseo pointed out, that for many of the cancers, Latinos had lower mortality rates than other groups, but because the population has grown so fast, one of the things that we've seen is that there has been a significant here, if we hopefully it'll stay here in table 1 here, we can see the major shifts, the major growth that has taken place among people who have the cases of cancer as well as the cancer deaths. More the period 1999 to 2016, more than a doubling in the cancer cases that were Latino, and close to a doubling in cancer deaths. And then if we take a look at the on the right hand side, figure 1, and I don't know for the scribbling that took place there, but what we see is if we take a look at what's going on with respect to population projections and keep the rates at which you have the cancer rates as well as the cancer death rates, you can see the significant growth that will take place among Latinos. So we can see then that what we've seen with the major shifts in growth in the Latino population, as well as the significant aging that we'll see in the Latino population, particularly because of a slowdown in fertility and a slowdown in migration, that we're going to see an aging Latino population. And those two trends then are going to significantly show the impact that Latinos will have on the changing face of cancer or the demography of cancer. And with that, the concluding remarks then is that Latinos continue to be the engine of US population change. This continues to be the case, but we've seen the slowdown in the Latino population, and what we will be seeing in the next few decades will be a significant aging in the Latino community. And due to the growth that is taking place in the Latino population alongside the aging that we're going to experience, we'll see that Latinos will increasingly play a role in the changing demography of cancer. And that's my presentation.
Thank you very much, Dr. Sines. We'll be holding questions, although you can put them in the chat until we get to the discussion after the second set of speakers. The next speaker is Dr. Mariana Carla Stern, who's going to talk about the overview of cancer-related burden in Hispanic populations.
Good morning and good afternoon, depending on where you are. I want to start by thanking the NCI for their initiative to organize this workshop, which is so timely and much needed. Special thanks to Drs. Elena, Lam, and Srinivasan for their vision and dedication to this initiative and for working so hard to make it happen. And also thanks to the rest of the NCI Planning Committee, as well as my colleagues in the External Advisory Board, Drs. Fejerman, Lynn Gomez, Martin, Napoles, and Ramirez. With this talk, I will do my best to provide an overview of the cancer burden among Hispanics. Throughout the rest of the workshop, there will be additional talks that will take a deeper dive into many of the observations I will share with you here. My goal is to provide a quick primer to get the conversation started. If we look at the cancer incidence trends for all cancers combined in the U.S., we see that the rate among the Hispanic population falls behind the rates for the non-Hispanic white and Black populations and are right above the Asian and Pacific Islander and the American Indian and Alaska Native populations. For decades, this has given the impression that the Hispanic population was okay, and perhaps this notion contributed to a disparity in cancer research among Hispanic populations, especially when compared to the majority population. However, unlike the majority population of non-Hispanic white individuals and other populations, among the Hispanic population, cancer is the #1 cause of death. Therefore, the burden of cancer in this population is quite considerable. In these graphs, I am showing you the incidence rates for these top 10 cancers and using colors to represent the ranking of incidence, with burgundy indicating the highest incidence and yellow the lowest. These top 10 cancers that affect men and women explain about 75% of the cancer burden. When we do this, we see that for the most part, Hispanic individuals suffer slightly less burden than non-Hispanic white and Black populations. We can see that among males, with the exception of non-Hodgkin's lymphoma, where Hispanic individuals are second to non-Hispanic white individuals in incidence, most other cancers rank lower. Among females, we see high ranking for melanoma, non-Hodgkin's lymphoma, kidney cancer, and leukemia. Lung cancer has the lowest incidence among Hispanic populations, both among males and females. A similar picture emerges when we focus on the top 8 cancers that contribute to close to 70% of cancer mortality. Among Hispanic males, with the exception of liver cancer and non-Hodgkin's lymphoma, most other cancers rank below non-Hispanic white and Black males. And in the case of lung cancer, they rank below all other groups. However, a different picture emerges when we focus on other cancers that do not rank among the top 10 that affect the entire US population. For example, among males, we see that Hispanic males have the second highest incidence of liver cancer, multiple myeloma, and gallbladder cancer. And among females, we see that they have the highest incidence of cervical cancer, stomach, and gallbladder cancer, and the second highest incidence of multiple myeloma and liver cancer. Given that many of these cancers are of relatively low incidence among the majority population in the US, historically they have received less attention compared to other cancers. Importantly, there are no routine screening programs for many of them, with the exception of cervical cancer. Even though many Asian countries with high incidence have routine screening for stomach cancer, we do not have such guidelines in the US, which contributes to further disparities for this cancer among Hispanic individuals, which, similarly to Asian individuals, are burdened by this cancer. As you will hear more during this workshop, liver cancer is not only a cancer of high burden for the Hispanic population, but the incidence trends are very worrisome. Among males, shown here, we see that while trends among Asian males seem to be going down, among Hispanic males, we do not see a similar trend, and currently the trend projects them to have higher incidence than Asian males. This worrisome trend is more pronounced among females, where we see a clear positive trend of increasing incidence rates, which have surpassed those among Asian females, who historically had the highest incidence rates. We see another worrisome trend for gastric cancer, which incidence rates that have not come down in the past decades, whereas those among Asian females have slowly decreased. Importantly, we see that for gastric cancer, Hispanic individuals show a greater burden of advanced diagnosis compared to other racial groups. This point further emphasizes the impact of lack of screening guidelines for stomach cancer among high-risk groups, and likely also emphasizes barriers to care among the Hispanic population. A recurring theme we are likely to hear across multiple talks during this workshop is that the U.S. Hispanic population is highly diverse, with individuals coming from many different countries in Latin America, having a complex admixture background descending from 3 different racial groups, such as Amerindians, Europeans, and Africans. Moreover, not only we still have many Hispanic immigrants coming to the U.S., but we have many Hispanic individuals who descend from many generations of U.S. Hispanics, which contributes to further admixing of this population with other U.S. populations. An important question that emerges is, how does the demographic and genetic diversity among U.S. Hispanics influence the cancer burden? If we take a look at the cancer burden across Latin America, we see that indeed there's a lot of heterogeneity when we consider all cancers combined, which can already give us a clue that indeed the origin of Hispanics in the U.S. should impact the cancer burden. We can see further heterogeneity and different patterns of it when we consider different cancers, such as these 4 of high burden among U.S. Hispanics. One of the first indications that this variability observed across Latin America could be reflected among Hispanic groups of different regions in the U.S. came from this paper from Dr. Pineiro, who will speak tomorrow, which was published almost a decade ago and was among the first to present incidence rates by region of origin among individuals living in Florida. This study highlighted the great disparity in incidence between Hispanic individuals of different regions. For example, we can see that Puerto Rican Hispanics have much higher incidence rates than Hispanic individuals that come from Mexico. Since then, there has been several other studies done for other regions and specific cancers that show similar patterns. If we focus on the role of social determinants on the cancer burden among Hispanics in the U.S., we also see interesting patterns that seem unique to the Hispanic population. In this study, also done about a decade ago, the investigators estimated the relative index of inequalities by comparing the incidence rates in the lowest socioeconomic status level to those among the highest SES. For breast and prostate cancer, we see that all racial ethnic groups had an index lower than 1, suggesting that the incidence of these cancers is higher with higher SES. However, this observation was more pronounced for Hispanics. Interestingly, for colorectal and lung cancer shown here, the same trend was observed, which was in contrast with what happens for other racial ethnic groups that have relative index of inequalities above 1. Therefore, whereas incidence rates increase with lower SES for most racial ethnic groups, among Hispanic individuals, the opposite was found. Finally, when considering the impact of genetic differences on the cancer burden among Hispanic populations, about a decade ago, Dr. Feckerman was one of the first to show that the differences in genetic ancestry among Hispanic women do seem to affect the cancer burden, with women of higher European ancestry having higher risk of developing breast cancer than those with lower European ancestry, even after adjusting for all well-established risk factors that could associate with genetic ancestry. Later work by Dr. Feckerman and her colleagues identified a specific genetic region that harbors a variant of Amerindian ancestry that seems to protect against breast cancer. Therefore, these and many other studies done since then confirm that indeed the heterogeneity among the U.S. Hispanic population seems to impact the cancer burden. Therefore, studying these sources of heterogeneity may give us useful insights into the cancer burden determinants. How and whether we should even consider this heterogeneity is something that we will debate during this workshop. We can look at other heterogeneous populations for guidance. For example, among the Asian population, the California Cancer Registry has adopted the use of countries of origin to report rates for Asian groups, particularly among Los Angeles County, where we have great representation of many different Asian populations. As you can see here in this report from the Cancer Surveillance Program from Los Angeles County, there is great variability in incidence rates across Asian populations, and these differences can be more pronounced for specific cancers. Knowing this can help facilitate studies of cancer etiology as well as guide cancer prevention efforts. However, among Hispanics, they're still reported as just one solid group. I would like to conclude with some questions for us to think about as we think how to move forward with cancer epidemiology studies among Hispanic populations. And we will have dedicated talks for some of these questions later today and during the rest of the workshop. Number one is the question of how should we group Hispanic individuals by different populations, and if so, which groups should we use? For example, we can compare foreign-born to US-born, we can use regions of origin, and there might be other determinants that we could consider. Number two is how can we improve data collection for Hispanic populations at the time of cancer registration or reporting? As you will hear later today and in other talks, when trying to emulate what has been done for other populations like Asians here in the US, there are a lot of missing data about regions of origin and nativity. How can we improve this? And finally, number three is the fact that the US population is the US Hispanic population is a fast-growing population, very much in transition, with a growing population of US Hispanics who may no longer descend from two Hispanic parents of the same origin. So how should we consider this in future studies? I will end here and leave you with these questions, which I know will be discussed further in several talks during the workshop, so I look forward to discussing them with all of you. Thank you, and I will be happy to answer any questions.
Thank you, Dr. Stern. Again, we're going to save questions until a little bit later, but please feel free to start putting questions in the chat, and they'll be collected when we go through the the panel discussion. So our next speaker is Dr. Alice Lovejoy, and the topic is who is considered Hispanic, applying novel approaches on data collection for future research.
Well, thank you so much for having me. The title of my talk today is Who is Considered Hispanic? Applying Novel Approaches to Data Collection for Future Research. I'm honored to be speaking with you today, and I'm really delighted to be presenting my first official presentation as an assistant professor in the Department of Public Health Sciences at UC Davis in the epidemiology division. And although in the program it says Stanford, and I'll be talking about the work that I've been doing at Stanford during my postdoc with Carlos Bustamante over the last 4 years. So one question that we've been thinking about for a while is really, how are we collecting and using racial and ethnic categories in the US? How can we even come up with recommendations and guidelines if we don't have a solid understanding of how categories that we use in the United States are playing out in research and medicine? So this is something we've looked at. And most of you from the United States should be familiar with the categories that we're asked to look at and select from all the time. And on forms, whether they be in clinical care settings, in research settings, on job applications. These are on the US Census, of course, and that is where our categories come from, is the United States Office of Management and Budget, which is under the Executive Office of the President. And in the research context, in 1993, the NIH was asked by Congress to start collecting demographic data based on these OMB categories for their research participants. And since then, there's been sort of unintended consequence, which is that researchers have interpreted these categories to be the analytic categories that should be used in analyses for research. And so we're in a situation where lots of research is produced, where results are reported by race and ethnicity per the US OMB categories. And then these have been integrated, of course, throughout clinical genetics testing labs and other forms in the healthcare system and in our medical records. So this is really kind of a ubiquitous framework that we're operating under. But as clean cut as the categories seem to be when you're just checking a box, they're really fuzzy. There's a lot of overlap conceptually in what these categories really mean and how we think about them. So when we zoom in and look at this term Hispanic, and we think about the question, who is considered Hispanic? I think the first question that we really need to get at is, how is this term defined and by whom? Whether we're looking at the individual level, institutions, or the data structures that we use to represent this category. And then how is it understood across contexts, cultural contexts, across history and individuals? What's their background and how are they perceiving this term based on their language or their place of origin? And who gets to decide who is and who is not Hispanic? There are many different ways that these decisions are made and how categories are assessed for individuals. And finally, what considerations factor into the decision to identify oneself or another person as Hispanic? So I'm going to walk you through each of these and give you an example of the US context, sort of lay the foundation for the next 3 days of this conference to think about Hispanic as not something we take for granted, but a concept that is fluid and context specific, and that we really need to think about who gets to be put in this category or who's placed in this category and for what purposes, and what impact does that have on our research and clinical practice, if that's relevant for you. So I think the first thing in thinking about the definition of Hispanic is that we have a categorical data problem. We have these complex concepts, race, ethnicity, and ancestry, that are all factoring into how one identifies or whether one identifies as Hispanic or non-Hispanic. And there are no universal definitions of race, ethnicity, and ancestry, but these that I provide here on the left are sort of my personal adaptations of the work of social scientists and anthropologists and others who have really delved into this for their life's work. So I dabble in it, but I think it's suffice to say that race is really about social context, cultural stereotypes, and power, and ideologies of inequality that are sort of constructed for the purpose of a social hierarchy and preserving social hierarchy and power dynamics. Ethnicity is more about community and language and culture, although I have to admit, as I've been putting this talk together, my view of ethnicity has gotten even fuzzier. So I think it's a really interesting one. And ancestry is really about, where do you come from? Where's your country of origin? Where's your family heritage? But in genomics, we talk specifically about ancestry as the inheritance of DNA that you can actually trace through the genome by looking at genotype data. But even ancestry is actually a little bit more ambiguous than I think folks tend to believe. So we can talk a little bit more about that. The next point that I want to make is about how understanding of Hispanic on the receiving end, regardless of how it's been defined by somebody else, how we might perceive Hispanic across different contexts. It wasn't until 1930 that someone who we might consider Hispanic was actually represented on the census, and it was just Mexican. So it was either you were white or you weren't white, and then if you weren't white, you had a race, and then it was one of these. The Brazilian racial categories are seen here, and they're all related to a color of some sort. In Mexico, it's interesting. When Mexico became a country, there was this unification effort such that now there's sort of this one Mexican national identity, and that's really what folks rally around. And so where you are, where you come from, who you are, what your background is, all of that factors into how you might understand this word Hispanic. Maybe you're scratching your head like, I have no idea what this means. And likely that is most people's reaction, understandably. And another factor, I think, is the purpose. So if you're considering whether you might identify as Hispanic, you might make a different decision, but based on whether you're answering a census, whether you're applying for a job, whether you're filling out a clinical form. So the purpose of when you're being asked and how you're being asked about this Hispanic identity, I think really matters. And then this is a very important point of who gets to decide whether someone is Hispanic or not. Over here on the left is a set of screenshots from clinical lab requisition forms that actually were gone through by Deb Ritter, one of my colleagues at Baylor College of Medicine on the Ancestry University Working Group of ClinGen. And we looked at all of the different categories. It turns out Hispanic made it on every single one of these. So that's definitely a ubiquitous concept in our clinical genetics world. And we wanted to know through our survey sort of if information is being used about patients, and it is, people are telling us that actually the majority say that race, ethnicity, and ancestry information are all at least somewhat important for clinical variant interpretation. So where are they getting this information from? So many people, the majority, 94%, say that they get race, ethnicity information directly from the patient. So in this case, it's selected by an individual for themselves. In other cases, 18% of our survey said that, well, sometimes it's recorded by another care provider, it's a medical record, and possibly without even asking the patient directly. So someone is actually looking at a patient and then checking Hispanic for them without having that conversation. And then finally, we were curious about folks that were actually using genetic ancestry inferred from a patient's DNA. And very few actually said that this is the case. Fewer than 5% of our respondents said that they were doing this, and most of them, I think, were doing it as part of a research study that they just happened to have for clinical genetics, but not as a sort of standard practice. So when we're talking about genomic medicine, and indeed probably a lot of research, any research before you actually have genetic data on your samples, we're talking about self-identified race and ethnicity. So this is an important question. So to summarize the factors that might contribute to a person being identified as Hispanic, or who is considered Hispanic, right? How is it defined and by whom? What is the purpose? Why is it being asked, and how will the data be used? What's the context? Where is it being asked? When and by whom? And who gets to decide? What's their motivation? What's their position? Do they have autonomy, agency? Do they feel safe to say that they are Hispanic or not? And then how are the data ascertained? And this is the one that I'm focused on in my methods development work that I'll sort of give you a brief teaser to towards the end of my talk today. So who defines it? Well, it's the US government, and the OMB, and the census. The purpose is a census category for ethnicity, but also it's used for lots of other things. Its definition is sort of ongoing. First instance, as we saw, was 1980, but you could argue that that discussion has been going on since as early as 1790, when we have sort of colonization of different parts of Latin America. And it's used in many different ways, as I mentioned, to estimate the Hispanic proportion of the population, but also throughout government research and potentially clinical care. So this category, this is our official definition, the Census Bureau, and it's lumped in with Latino or Spanish origin. So this is a category of Hispanic, Latino, or Spanish origin, including all individuals who identify with one or more nationalities or ethnic groups originating in Mexico, Puerto Rico, Cuba, Central and South America, and other Spanish cultures. And so then they go on to give some examples of specific parts of the world. So this is very closely tied to colonization. If you look at the countries that they're discussing, these are the Spanish and Portuguese empires around 1790. And then if you look at sort of modern day Latin America, these are where Romance languages are spoken. So you can't really separate the concept of Hispanic, I think, from colonization and sort of how that's impacted population structure and how we think about demographics. So in the US Census, these are data from the 2019 American Community Survey, 18% of the US population is estimated to be Hispanic or Latino. Now the question is person one of Hispanic, Latino, or Spanish origin? And you can check one of these or no, or if yes, there's Mexican, Puerto Rican, Cuban, or another Hispanic, Latino, or Spanish origin. For example, some of these others, so basically other. And this is roughly 5% of the US population. We're talking about sort of being like this other sort of amorphous Hispanic, Latino, Spanish origin person. So this is the question I've been thinking about and working on from a methods development perspective for a few years now. I'm really excited to delve into this for my lab. Submitted a few proposals on it, so we'll see what happens, but I'm going to keep working on it and give you a little teaser with a pilot I've been working on with the U.S. National Marrow Donor Program data. So I looked at Hispanics in the NMDP, and this is a large sample. There's 105,000 individuals in this survey, and they did an extensive demographic survey where they asked about ancestry and race in all sorts of ways. How do you identify racially? How do you think others identify you? And then what's your personal ancestry? It's ancestry of all of your grandparents. So there's this extensive survey, but I wanted to keep it fairly minimal for this analysis, just to show you the contrast of how much more detail we can get when we ask open-ended questions. So if we're just looking at a single race category, and indeed, when you look at the demographics in research, often you see all of the numbers and the proportions by these single race categories, and it may include Hispanic, Latino, and then two or more races is its own little category. So if we just start thinking about this in terms of how demographics are typically reported, we're looking at it like this. There are 527 Hispanic individuals with just one category that they've selected as a sort of a single race designation. Now, if you allow for multiple categories to be selected, and you're going to actually count and represent those people in some way, you see this increase in the folks who are identifying as American Indian Alaska Native, Asian, Native Hawaiian, or Pacific Islander. And of course, you have this huge gap in other, where if you're allowing people to select more than one, and you're taking that into consideration in your analysis or in your reporting, you're getting a lot more individuals in your sample who actually get represented, because again, most of these groups report more than one. And then if you go further and you go into this other category and actually see what people are writing, you start to get at some very interesting details. So you start to get information about languages and nationalities and ancestries that you don't necessarily capture otherwise. So keep in mind, all of these folks identified as Hispanic. So I'm working on a methods development project to actually map all of these layers of diversity across all of our population. So if we have a layer in our data structure for race, for language, for nationality, for ancestry, you start to build out a a layered network of variables, you can start to map the relationships between the variables, both within them. So by mapping individual text strings that are being input by individuals in their own languages, in their own words, and you can preserve the complexity of how somebody identifies in this graph-based data structure that you can then use to do your study design. You can look at, maybe do a causal pathway analysis based on how these variables are connected to one another. And ultimately, we can combine this information into association studies where you're adding layers of the network that also include things like genetic data, other social determinants of health, perhaps, that you can really start to gain a richer picture of the social, demographic, and genetic components of complex disease. So when you're talking about and thinking about epidemiologic research methods, this can be a potentially really powerful tool if leveraged appropriately, and of course, taking into consideration all of the history, the ethical, legal, social implications, and of course, how to really operationalize this in a way that is going to be meaningful and useful. So to summarize, racial and ethnic frameworks are socially, politically, and culturally derived. Our categorical data structures that we use collapse racial and ethnic identities and genetic ancestry. The Hispanic population is not well defined at all. And our existing data frameworks are not really sufficient to represent the massive amounts of diversity across multiple dimensions that we have in our, particularly in the US population, but globally as well. And I suggest that open-ended demographic questions like what regions of the world or countries do you have any ancestry from, for example, might be combined with categorical data to enhance precision in our epidemiology research and in genomics. So I hope that gives you some food for thought. And I'd like to thank, as I mentioned, Jill Hollenbach for her collaboration, Laura Fairman at UC Davis for inviting me, Amanda Gutierrez for some last minute conversations about this, just to make sure I didn't have any blind spots. And then of course, all the colleagues that I mentioned from the ClinGen group, and Ben Swanham at NHGRI, who's also been an important mentor for me on these projects. So thank you very much. And thank you to NCI for having me. And I look forward to our discussion.
Thank you very much, Dr. Popejoy. We're going to move on to the next three so that we have time for the panel discussion. So our next three speakers are Dr. Scarlett Lynn Gomez, who will be talking on characterizing the heterogeneity of U.S. Hispanic populations and associated challenges to cancer epidemiology research, followed by Marcia Cruz Correa on cancer epidemiology research in Puerto Ricans, and then by Laura Feherman, who will be talking on what variables should be collected to enable advancing cancer research in Hispanics, including diversity of subgroups, pooling data, and what are the challenges and opportunities. And so we will start with Dr. Gomez.
Good morning. Thank you for that nice introduction. I'm going to try to see if I can advance the slides. There we go. Pleased to be here with this incredible panel in this multi-day workshop that I'm so glad to see NCI organizing together with an IMHD. I'm going to spend the next 10 to 15 minutes talking about kind of giving an overview of the heterogeneity in terms of sociodemographics of the Hispanic population within the US. And how we might expect that to translate into differences in cancer risk factors and health behaviors, as well as the cancer burden. And then with some closing thoughts about what might we do about that in terms of challenges, but opportunities that present to us in terms of cancer epidemiologic research. The talks this morning have actually set a really nice stage for what I'm going to present, and you'll certainly notice that there's some overlap, but hopefully during the discussion we can really kind of try to pull all of this together. So these are the latest hot off the press data from the 2020 census. Overall in the US, the Hispanic population comprised 18.7% of the US, but you could see from this heat map by state that there are differences in terms of the percent of the total population of Hispanics across the states. We see here in California, as well as the southern states of Arizona, Texas, Florida, that Hispanics comprise 25% or more of the population. The largest being New Mexico, where Hispanics are almost half of the population, 47.7%, followed by California at almost 40% and Texas at almost 40%. We also see that there's actually heterogeneity in terms of the increase in the size of these populations by state, with some of our Midwest states, North Dakota, seeing an almost 150% increase in the Hispanic population over the past 10 years from 2010 to 2020. South Dakota and Vermont seeing it's about a 70 to 75% increase. Louisiana and Tennessee also seeing similarly high increases. And as we would expect, those states with already high proportions of the Hispanic population, California, New Mexico, Texas, are seeing smaller increases in the Hispanic population. And I'll show you in the next few slides, but you've already heard from Eliseo why that pattern, why we're seeing that pattern. As you've heard from all the speakers, this is an incredibly diverse population. Alice presented information about how these ethnicity and Hispanic origin data are collected from the US Census. So these data are from the census compiled by the Pew Research Center. And it shows the distribution in terms of population counts of the 30 different Hispanic origin groups. The largest, as we all know, is the Mexican group. They comprise 61.9% of this Hispanic population. That's followed by Puerto Ricans at almost 10%, Cubans and Salvadorans at about 4%. But you can certainly see here the diversity in terms of the number of groups. And so when we think about presenting cancer statistics, just think about these think about the groups that you're seeing here on the left and the different groups that go into that categorization. So I want to present a bit more demographic data that tries to illustrate this heterogeneity. This again are data from the Pew, and it shows that there's heterogeneity in terms of the distribution of the Hispanic origin groups by geography. And what we're seeing is that by Hispanic origin, Latino populations are much more diverse along the eastern seaboard states compared to the West and the South and the Southwest. So for example, in California, specifically here in LA, Mexicans comprise 77% of the population. Also in Houston, Texas, 73% of the population. But then we move on to Orlando, New York, Rhode Island, Miami, Washington, DC. We see a much more even distribution of the Hispanic origin groups. And so this graph illustrates the point that Eliseo had made, which is that we're seeing a decline in the proportion of Hispanic and Latinx immigrants in the US over the past 10 to 20 years. In fact, the immigrant share has fallen in 12 of the 14 largest Latino groups in the past 20 years. Two of the groups in which we're seeing increases in immigrants are Venezuelans and the Spaniards. But for the most part, we actually see comparable declines in the percentage of immigrants across most of these Hispanic groups. And of course, as we would expect, and as you've already started to hear, there is vast sociodemographic heterogeneity. These are indicators for sociodemographic indicators from the American Community Survey, also again based on data compiled by the Pew Research Center. And I've shown here the distributions for these 4 demographic indicators across the groups for which we have data from the ACS. And so looking here at the percentage college graduates, we see that the range in percent college graduate ranges from 10% among Guatemalans and Salvadorans and Hondurans and Mexicans to greater than 40% among Argentines, 55% among Venezuelans. It's a huge spread in terms of education. Similarly, percent living in poverty, we see ranges from a low of less than 10% among Argentines to as high as nearly 25%, quarter of the population among Guatemalans and Hondurans. median household income, we also see heterogeneity ranging from a little over 40K per year in terms of annual household income among Dominicans and Puerto Ricans and Hondurans, to as high as over 60K among Spaniards and Argentines. And then homeowners, we also see some heterogeneity ranging from less than 30% being homeowners among Dominicans and Hondurans to as high as over 60% among Spaniards. And so naturally, we would expect this to translate into differences in health behaviors and health outcomes. These are data from the California Health Interview Survey, which is a rolling survey that's conducted by the UCLA Policy Center. And I've shown, I have to just note that I had a really difficult time finding national statistics for health behaviors and outcomes. I'm sure this data exists out there. I was not able to find it. And so I want to acknowledge that California, in terms of just focusing on California data, is really not the best representation of data for Hispanics and Hispanic origin groups across the US. But nonetheless, this is what I was able to find in terms of the most current data. So what you can see here is that in terms, I'm just going to walk through a few of these. In terms of the percentage that are obese, we see a vast variation. The first column refers to all Latinos in California combined. We see comparing the high of almost 40% among foreign-born Mexicans to a low of 16% among South Americans. In terms of smoking, a high of 12.7% among Mexican US born to 8.6% among Guatemalans. In terms of health behaviors, diabetes, we see ranges from a high of 17% among foreign-born Mexicans to 4.6% among South Americans, reporting self-fair or poor health, 38% among Mexican foreign-born to 17.7% among South Americans, and having high blood pressure ranges from 30% among Mexican foreign-borns to 14% among South Americans. Now, one observation that's interesting here based on these health behavior data from CHIS are the differences comparing the foreign-born and the US-born Mexicans, for which in California, we do have robust data to be able to split this group out by nativity. And you see for the most part here that health behaviors do tend to be, sort of varies, do tend to be worse in terms of healthful behaviors among US-born compared to foreign-born. But in terms of health outcomes, they are worse for foreign-born Mexicans compared to US-born Mexicans. And so, of course, we would expect this heterogeneity in terms of health behaviors to translate into differences in cancer burden. You've already heard from some of our previous speakers about some of the disparities in cancer incidence and mortality and survival across Hispanic groups. And there are increasingly more and more reports that we're seeing that attempt to split out by Hispanic origin groups. You'll hear much later on about some of the limitations in terms of data availability for us to really be able to properly report cancer burden by Hispanic subgroups. But in any case, this was a paper published in CEBP 2019 by Stephen Zamora et al. That I had the opportunity to collaborate on. And this is just one of the tables from that paper, and it shows the percent proportional mortality, that is the percent of deaths due to these specific cancer sites as a proportion of overall cancer deaths. And you could actually see that there is actually some consistency across the Hispanic origin groups in terms of proportional mortality. So focusing on the top half of the panel among males, we see that lung cancer is the #1 contributor to deaths across all of these Hispanic origin groups, although the proportion in terms of the absolute number varies from a high of almost a third of deaths due to lung cancer among Cubans to 14.7% among Central or South Americans. The next second most common contributor to cancer-related deaths now varies across the different Hispanic origin groups, colon cancer for Mexicans, followed prostate cancer for Cubans and Central or South Americans. But as you had heard previously, liver cancer for Puerto Ricans, which is unusual as liver cancer doesn't even show up in the top 5 among non-Hispanic white males. We also see liver cancer ranking as a top contributor of deaths among Mexicans, which is the number 3 cause of deaths, cancer-related deaths, and number 5 for Cubans and Central or South Americans. Now, for females, we also see similarity across all of the Hispanic origin groups, with breast cancer as the number 1 contributor of cancer-related deaths across all of these groups, which is interesting in contrast to non-Hispanic whites, where lung cancer remains the number 1 cause of cancer-related deaths for non-Hispanic whites, followed by breast cancer. Lung cancer is the 2nd most common contributor to cancer-related deaths, followed by colon cancer, pancreatic cancer, and then ovarian or stomach cancer. So I'm not sure if you can see the top panel. What this header says is cancer mortality rate ratios comparing California Mexicans to Mexicans living in Mexico. So this is a publication by my colleague Paula Pinheiro, who you'll be hearing from later in the day. And what this publication shows is it takes cancer mortality data from the state of California, stratified by US born, foreign born. So the US born would be the Mexican Americans represented in the gray bars here. Foreign born would be the Mexican immigrants. And these are rate ratios, mortality rate ratios comparing to those living in Mexico. So this type of migrant study is a really powerful, it's something we've been long doing with immigrant populations, but is really a very powerful way for us to be able to really think about how rapid the transition is in terms of its impact on the cancer burden. And you can just see here at a glance that transition is incredibly rapid. For most cancers here, we're seeing higher mortality among Mexican immigrants, that is the foreign born, when we compare to those living in Mexico, but even higher mortality among US born Mexican Americans. The exceptions here, if you see, I should have darkened the line here at 1, would be prostate cancer and stomach cancer. And that was for males. This is for females. Similarly, we see very rapid shifts going from Mexicans in Mexico to foreign-born Mexicans to US-born Mexicans in California. And so these data, these rapid shifts, suggest that the shift happened very rapidly and is likely due to shifts in incidence versus shifts in survival, because we know that for the most part, survival actually among foreign-born Mexicans are worse than that compared to US-born Mexicans. And so finally, this was a very high level overview, and you'll be hearing more about specific burden in terms of specific cancer sites. Lingering thoughts about what challenges this heterogeneity presents to us, and then what should we do moving forward. Certainly we need to disaggregate, but really how granular can we go? You see that there are some very, very small. Some of those 30 subgroups are very small in terms of numbers. As NCI and others have been advocating, we need better statistical approaches to be developed for studying small populations. As you've also heard, and you'll be hearing more, that Hispanic origin is often not captured in health surveys, cancer registries, health systems, hospital data, and we know that this information is missing for 40% of Hispanic cases in cancer registry data. I was very pleased to hear from Bob some new initiatives that are going on to improve the quality and completeness of these data. We also see a lack of standardization in how data are collected across these different sources, which makes pooling data across sources, consortium studies, very challenging. And of course, as you've seen, there's vast heterogeneity, but the data that are used, the sociodemographic data that are used to capture that heterogeneity is often not captured. So we need to ensure that we are including these data in health surveys, cancer registries, hospital healthcare systems, that these include things like nativity, immigration factors, language, SCS. But there are opportunities that may be presented to us in terms of leveraging their heterogeneity. as we saw heterogeneity in terms of risk factors and disease risk. And so I think employing novel as well as traditional designs like migrant studies, intergenerational studies really can provide us opportunities for elucidating, identifying novel risk factors in their pathways. And finally, this is my last slide as a call to action for all of us who are gathered here with interest in cancer epidemiology in Hispanic populations. So we should recognize that there is heterogeneity and really embrace the heterogeneity. I mean to disaggregate in terms of the research that we conduct. And I think that it's important to critically assess and ask the question of when it's appropriate to compare to white data. I feel that it's a knee-jerk reaction to always feel like we need to compare data to non-Hispanic whites. And this is an explicit message I'm sending out there to those of us who sit on study sections. We need to focus on the unique factors that are associated with the lived experiences of these unique heterogeneous populations and think about applying approaches such as life course epidemiology. We also need to focus on the impact of structural and social determinants, examine intersectionality among multiple marginalized social statuses, and of course, understand language needs to maximize inclusivity in our studies. Thank you.
So good afternoon, and thank you for the opportunity of being with this team of amazing investigators and presenting some of the data that we have been working on from the people that live in Puerto Rico and those Puerto Ricans that are located also in the national USA. So let's see if I can do this well. Okay, very good. So the title that was given to me was how to use epidemiological research to really try to understand some of the differences, disparities, and diversity that we see among patients that have come from Hispanic background. And I'm going to focus specifically in data from Puerto Rico. So we've heard this morning before and that how diverse are the different Hispanic groups. And I want to do now a little bit of a closing into the Puerto Ricans, Hispanics. And as Scarlett was mentioning, Puerto Rican Hispanics represent close to 10% of all US Hispanics. And in the last 10 to 20 years, there have been a lot of changes in the demographics of the island. For instance, there has been a large immigration of Puerto Ricans from the island into the mainland USA. In fact, our census, the last census data showed evidence that over 1 million Puerto Ricans have moved from the island to mainland USA. So that brings a lot of changes now in those Hispanics that live in Puerto Rico versus those that live in the US. There are also very important differences with regards to some of the exposures, such as tobacco. There's lower tobacco among Puerto Rican Hispanics. There are high levels of obesity, diabetes, HPV, also hepatitis C virus and H. pylori. And you know that all these are risk factors for cancers that we do screening. And it was mentioned briefly that liver cancer is seen high among the top cancers among Puerto Rican Hispanics, and hepatitis C had been part of the reason why, because treatment for hepatitis C didn't start in Puerto Rico until a few years ago, at least for over 50% of all the community that are in the public health system. So I want to share with you different approaches and models that can be used, but focusing, of course, on the epidemiological models that we have used in Puerto Rico to try to answer some of the questions that come to mind as clinical investigations and try to understand why we're seeing these differences. Like, I'm a gastrointestinal oncologist, and I work very close with patients that present with colorectal and gastric cancer. And colorectal cancer has been one of those cancers that we have seen to continue to increase among certain groups, and Puerto Rican Hispanics have been some of those. Not only that, we have seen how younger people are diagnosed with colorectal cancer, and now we know the guidelines have been lowered to start screening at age 40, 45. So some of the data that help to support that changes in policy come from previous publications, including the group from the University of Puerto Rico, the School of Public Health, led by several investigators, including Dr. Tortoledo and Dr. Ana Patricia. among others. And I'm going to share with you different examples of how to use the diverse models to answer questions that are very relevant to try to understand the Hispanics. So this is data that it's focused again in Puerto Rico, comes from the Central Cancer Registry, which has been in part of Puerto Rico over the last 50 years. You can see the top cancers in the period of 2012 to 2016 for male and female. And you can see how prostate, colon, and lung are among the top 3, and how for female breast, thyroid, which is not a common cancer when you look at other groups, and colon continues to be among the top 3. And again, we already discussed liver among men. And the other slide I was talking about mortality. So using the data from the registry and comparing it with national registries, such as the SEER database, our group and others from the Puerto Rico Cancer Center were able to evaluate differences in incidence, age-adjusted rate, comparing the Puerto Rican Hispanics to other Hispanic groups. And I just want to call your attention to when you look at the 5 cancers that were evaluated, in yellow is the bar that represents the Puerto Rican Hispanics. And you can see how for prostate cancer, there was a increase compared in Puerto Rican Hispanics as compared to other of the groups. Similarly, you can see in colorectal, as I was mentioning before, and also in thyroid. And I think the next slide, let's make sure, yes. So here we look deeper and we wanted to specifically look at colorectal cancer, and we compare for both female and male age-adjusted incidence rate. And you can see that Puerto Rican, and it's the second category, had the second highest incidence rate as compared to the other races, including US Hispanics, which is of course a heterogeneous groups, but only lower than African and Americans. So another way that we can look at databases to try to understand the disease, in this particular case, colorectal cancer, is by using database that are for claims, right, for health insurance. And this, we wanted to understand whether or not there were differences between the type of insurance that the patient had in Puerto Rico and the outcomes. And this was published a few years ago. The lead investigator was Dr. Karen Ortiz. And the question was whether or not delays in access to healthcare, such as primary delay, which is how long it takes from the time that someone has symptoms to the time that they are referred to the primary physicians, secondary delays, which is from the time that they present with symptoms to the primary physician to the time that we have a confirmed diagnosis, and tertiary delay, which is once you have a diagnosis, let's say diagnosis of colorectal cancer, how long does it take to start treatment? And the data has shown that any changes or any delays in any of those 3 particular delays will impact the outcome of patients. And we wanted to use the health claims data from the public health system, which at that particular moment in time, there were patients within the same health insurance that had the government insurance and the private insurance. And we were able to show that, in fact, and in individuals that had the government insurance, which in this graph you can see we are plotting 2 lines, one is in gray, the other one is in orange, and we are talking about relative survival. So as you can see, the 2 lines never cross. So individuals that were part of the non-government health plan or insurance had better outcomes, and in this case was relative survival at the 3 time points. We adjusted for the things that were available, and this became a very important piece of legislation that we were able, a piece of science that we were able to use with the Department of Health to allow us to change some of the guidelines and time to start performing colorectal cancer screening. I want to switch gears very briefly and talk about the importance of having data that comes from the molecular basis, right? Of not only somatic mutations but also germline changes. And I'm showing in this particular slide how the treatment of cancer has changed dramatically in the last 10 to 20 years, where now it is so important to understand what is the genomic or genetic profile of your patient before you even decide therapy. And one way to try to understand that is by doing clinic and population-based data registries, rather. Here, I'm showing you how is the way that we are organized. So for the last 15 years, we've had in Puerto Rico one large database that now has over 5,000 patients that have been diagnosed with either colorectal cancer, gastric cancer, and also normal controls. And basically, this particular biological specimen banking has allowed us to look at multiple questions and help different levels of students, graduate students, doctoral students, faculty, even high school students, to help them understand, and learn the process of conducting research using databases. In this particular case, our registry. And this is just to show you some of the things that we have been able to identify. So specifically for colorectal cancer, we were able to show that the molecular changes that were commonly present among Puerto Rican Hispanics are not commonly expressed in other groups. So the carcinogenic, the particular oncogenes that get mutated, and this is using a genetic epidemiology approach by using a population and a clinic-based a registry using standardized methods. And using the same large database, we were able to examine the role of ancestry and colorectal cancer risk. Briefly, we heard earlier today how ancestral background is important and how it might allow us to understand why certain groups have higher risk of developing a disease or worse response to outcomes, right, associated to their ancestral background. So we look at our patients and close to 1,000 of them, and we were able to show how, let me go back one slide, sorry, how patients that had an African ancestry were more likely than those that did not to have their colorectal cancer located in the distal side of the colon. Similarly, their outcomes were worse. They had tumors that were poorly differentiated, which is also correlated to poor outcomes. So again, using this particular database, population-based database that allows us to look at outcomes in this particular case. I want to finalize with the using commercially available databases. So, many of the companies that we use for clinical purposes, they have available data that you can mine. And in this case, we put together a collaboration between the University of Puerto Rico and CARI's, the Precision Oncology Alliance. And we look at the first 937 individuals that had commercial testing of their tumors. And you can see the distribution. Most of them had either colorectal cancer or breast cancer. There was a 13% that had lung cancer and some of the other cancers. And here you can see the age range distribution of those 931 patients and the female and male distribution. But then we did something very exciting, and this is not published yet, and we're working on, and this is the data from colorectal cancers. So what we did is that we compared that commercially available database with TCGA data, also with Gini project, and then we look at Hispanics and non-Hispanics. And here, just one slide, just to show you how beautiful you can, really explore and start to understand the differences that are so important in the way that we perceive the risk of a particular group, in this case of Hispanics from Puerto Rico. And you can see, comparing the Puerto Rican Hispanics with the TCGA data and the Hispanics from the Gini project, you can see that there were clear differences with certain oncogenes, which make those tumors less likely to respond to therapy or more likely to progress and metastasize. So using a database, we were able to start to understand some of those carcinogenic processes that might drive mutation. I'm going to finalize talking very briefly about two projects that we have started, again, looking at, in this case, pathology database. So we've talked about, cancer registries, database claims, population registries, and now I want to talk a little bit about pathology databases. So we wanted to understand specifically one of the most important risk factors for gastric cancer. Why? Because gastric cancer is common also in the island, still one of the top 5 cancer-related deaths among men. And we've also started to see how younger men are being diagnosed with gastric cancer, and it should be decreasing like everyone else. So, GIM is the precursor lesion, and it's a description that is done by the pathologist. And what we did, we collaborated with one of the largest pathology labs in Puerto Rico, and that represent close to 40% of all the biopsies that are done by gastroenterologists. And we look at over 43,000 biopsies, that came from endoscopies, and we were able to determine the prevalence of this particular precursor. And you can see here the data. So the summary of this presentation was how we are able to use different approaches from available databases, including national databases or cancer registries, how this can help us identify, in our case, I was showing you specifically colorectal cancer, but this applies to many other aspects. I show you some data on how non-European ancestry was associated with worse outcomes. And, I'll have to finalize saying that epidemiological research, classic epidemiological research, database, population-based research, it's key. It's key to guide our hypothesis, to inspire us, and to really put together projects and programs that allow us to impact the community that we serve. And with that, I want to thank for the opportunity for being part of this. That's the group in Puerto Rico, in Colorectal Cancer Awareness Day.
Thank you very much. And our last speaker before the panel is Dr. Laura Fejerman, who's going to be talking about what variables should be collected to enable advancing cancer research in Hispanics and what are the challenges and opportunities.
Thank you, everyone, for being here. And, I'm the last of a long series of presentations, so please bear with me. I think it's a relatively short presentation and different to what others presented, in the sense that I'm going to just give you food for thought. You can agree or disagree. It's more like a broad, I'm hoping to trigger general discussions. I have no prescriptive, I'm not going to tell you what variables we should collect, but more specifically talk broadly about what I think would be important to understand, and maybe the type of data we should collect to advance cancer research and epidemiology in what I'm going to call HLs, which represents a kind of non-problematic version of Hispanics, Latinx, Latinas, Latinos, and different versions of or words we use to refer to the group of individuals in the US who self-identify as belonging to one of these work groups, or individuals in Latin America. And I approached the question of what variables we should collect using an expanded version of what was presented, I think it was in 2017, as the research framework from the National Institute of Minority Health and Health Disparities, which itself was an adaptation from the eco-social framework, adding dimensions of influence and a life course approach as well. The expansion really involves acknowledging that these different domains of influence on health over the life course include the individual, are intersected by individual level, interpersonal, community, society, but also congruent with what's coming up as kind of a more global perspective on health and interspecies perspective. We're adding these two, I highlighted here, levels, which would be interspecies and planetary, or you can also call it global. And this allows for the discussion today, this is relevant because it kind of explicitly incorporates things like migration and mobility, or for example, the distribution globally of medicine and the production of health. So with this broad research framework, we can then think about cancer as a very complex trait when we're talking about HLs. So usually, cancer is defined as a complex trait when you have genes and the environmental exposures and interaction between the two. You have intermediate phenotypes, and then, here I represent cancers with different types and heterogeneity within the different types. But when we think about HLs, and this also applies to when we're talking about other groups in the US, which have large percent of individuals coming from originally from other regions and countries, we have this kind of between and within country variation that adds complexity to the environmental exposures, fragmenting what we see after, when we think about life course. Here, what we have is like part of your life might, you might be exposed to a certain level of factors where you move and then you're exposed to a totally different set of factors, and then genetic admixture adding to the complexity in the genetics and the interaction between the genetically admixed background plus the heterogeneity in the environmental exposures. So first, I will highlight why it's important to think about complexity when collecting demographic data in cancer epidemiology in HLs, and then briefly about lifestyle environmental exposures. I will not talk to you about, for example, collecting tumor characteristics or outcome data, which is not because it's not important, it's just for brevity and to focus my talk today. Cancer statistics or cancer epidemiology based on broad categories such as HLs or even nationality should be the first step in our work. We are all very aware, even before listening to the talks today, we already knew that HLs included a very heterogeneous group of individuals with different family origins in different countries and with people who are culturally and genetically diverse. However, here in the US, when we're doing research in this population, we tend to forget, or at least due to complexities, kind of ignore the great variation that exists within countries in Latin America, and hence within immigrants in the US. To the left, you can see pictures of peoples and places in Argentina. To the right, I put a couple of pictures and places, cities in Peru. This is just, there's like a couple of examples, but really these countries are amazingly rich in different, climates and ecological areas with different exposures to bacteria and viruses. Culturally, groups can be very different, and sometimes you have a lot more similarity in terms of what an anthropologist would call ethnicity and lifestyle when you group people from Peru and Argentina that come from the same region. For example, the north of Argentina and the south of Peru have very similar populations. So all this heterogeneity within countries is at the level of demographic variables we usually collect, like income, educational attainment, access to care, and genetic ancestry. For example, regarding genetic ancestry proportions, you can see here, this is one of my favorite pictures looking at genetic ancestry distribution in Colombia, Brazil, Chile, Mexico, and Peru. The indigenous American ancestral component is in blue, the African component in green, and the European in red or orange. And so you can clearly see here how within the countries you have quite a lot of variation, and sometimes you have regions that are more similar between countries compared to regions within. And one thing that is very important when we think about genetic epidemiology and genetic ancestry is that in the US and in Latin America, ancestry correlates not only with unique biological factors in terms of genetic variation, but actually ancestry correlates with a lot of non-genetic factors like level of education or SES. In the US, for example, ancestry correlates with English fluency. Here I included a figure from a study by Mark Villa et al. From 2011 looking at the island of Puerto Rico and the correlation between socioeconomic status and African ancestry. And you can see that the correlation between these social factors and ancestry also will change depending on the ancestry variation in the region of the particular country you're looking at, with, for example, the East region here of Puerto Rico having large variation in the African component, and also a larger difference in the association, the correlation between ancestry and SES, while in regions where this component is smaller, then you see less of a correlation. Of course, Mariana mentioned this work when she presented at the beginning, where we did a genome-wide association study of breast cancer and found in Latinos from the US, and also we included, we replicated this in other populations, including populations in Latin America, where ancestry was associating with breast cancer risk. The more European, the higher the risk. And eventually we, through a genome-wide association study, we found a protective polymorphism in the 6q25 region, which is a region of interest for breast cancer, and where other variants associated with breast cancer risk have been reported in other populations. But you can see here that this variant, which is actually strongly protective, is only present among Latin American populations, and the allele frequency of the protective allele correlates with the proportion of indigenous ancestry in those particular populations. And so, for example, in Peru, this variant, this protective variant, has the highest frequency. So this to say that genetic ancestry can be associated with outcomes and with phenotypes because of multiple reasons. It could be partly to genetics, like in the breast cancer case, we found this polymorphism. I don't think, there's other examples for other cancer types, and I'm sure there's more to be found as we increase sample sizes for genetic studies in Latinos. But clearly there's a lot of correlation that is due to access to care, socioeconomic status, and other factors that are not genetics. And when we do association studies and epidemiology, we should keep always that in mind before we interpret results. The other point I want to make, and Alicia talked about how Latinos are, we share a lot of things, but also there are differences. And again, I think there are not so many differences between countries, but actually within countries, as it happens in the US. So for example, if we look at census data in the US, I just selected one variable, which is access to internet. You can see there's variation between states. If you look at census data, or this is data from the National Institute of Statistics, Geography and Informatics in Mexico, you can see that the different regions in Mexico have different proportion of access to internet as well. And therefore, when we're looking at information as access or any other things that we think are relevant for cancer risk, we cannot just consider, that everyone who comes from Mexico will have similar exposures. We've really been exposed to different levels of factors, and socioeconomic status varies, and this is as important as now when we do epidemiology in the US. So when I'm kind of quickly gonna touch on the complexity regarding lifestyle environmental exposures and what we should measure, or what variables we should include. And here, this is one of my favorite pictures, and I'm hungry because it's almost lunchtime for us. But you can see Latin American countries have different dishes and diets, and we're exposed to different foods. There's also a lot of variation within countries, and there's change through time. One of the important factors, I think, that we should consider is how, I'm gonna talk about really how, going back to the zip code, but now from a exposure to lifestyle and contaminants perspective. It's really important, as we're tracking zip code in the US when we do epidemiology, and we want to know what were you exposed to when you were young. In the US, it'll be important to know for the Latinos we study here who came from other countries, what were their exposures like when they were in Latin America. And we know that early age exposures are important for cancer development. So this is not trivial, and we should think about it. So I'm throwing this out there. I'm sure people are already doing this kind of things in researching Hispanics, but it's clearly not general yet. But I think there's more and more data from wearables, biomarkers of exposure that we can measure in urine. For example, stress measures that you can get from hair, or biomarkers of stress in blood. There's mass techniques, I can't say it. It's moving fast and improving, and now we can correlate markers in urine to actual dietary exposure. So I think we should stop trying to get information from questionnaires about what you ate when you were young, and start collecting today in cohorts and international cohorts in particular. So historical data is going to be important. I think we should keep this in mind. Today, we have a lot of monitors of air quality everywhere. As we move forward in time, we'll be able to correlate exposures when you were young to your lung cancer risk, for example. So in summary, I just wanted to highlight that we should always consider the intersection of multiple relevant dimensions and levels, and a life course perspective when doing epidemiology research, specifically in very complex populations like Hispanics, Latinos. These broad categories should be the same as nationality, should be just the first step in epidemiological research. Genetic ancestry varies within countries and between countries, and is associated both with genetic and not genetic factors, and this is important. Zip code is important in Latin America and not only in the US, so we should start thinking about this when we design studies with a life course perspective, when we think about those individuals like me who lived their first 24 years of life in a particular context and then change. I'm sure all the meat I ate during those 24 years, it's important for my future health. Early life exposures in the country of origin among immigrants in the US are relevant to understand cancer incidence. I propose zip code tracking internationally. Exposures to carcinogenic agents can be measured using different monitors, wearables, and biomarkers. And I think as time passes by and technologies improve, this will get easier and easier, but we should be thinking about the future now and try to get these measures in place. And also historic data already exists for some exposures, and really thinking about the next 20 years would be really important, just to keep in mind that, you know, people change, and it might be more important the quality of the air that you were exposed at age 14 or 15, and not so much the quality of air that you're exposed today. So I'm gonna talk more about international collaborators. This is a theme for me. I think you can't do cancer therapy in Hispanic Latinos without thinking globally and understanding diversity of exposures and the history of migration among US Latinos. Thank you.
Thank you very much, Dr. Fairman. Now we're going to go into the panel discussion that will include the 6 speakers who've spoken as potential respondents. So let me look quickly at the questions that have come up. And are there people now, besides in the chat, who have questions that they'd like to ask? All right, not hearing those. So the one question I had before I get to these is, we know that cancer is a disease of long latency. And so perhaps a little bit related to what Dr. Fairman said, there are multiple points in time at which it may be important to characterize perhaps exposures, where somebody's living, but we have some variables that are once in a lifetime, like ethnicity, and we have others that people carry with them as they move through the cancer etiologic period. Does anybody have any suggestions about how we might deal with those time-related issues, keeping in mind that cancer is a disease of long latency? Anyone care to respond?
So just, yeah, I agree with you, Dr. Trapido. I think that has been one of the challenges that we face, because with a majority of an immigrant population, we don't have access to a lot of data of early life exposures. And as Dr. Feckerman was saying, those can be very important in understanding the determinants for cancer formation. So I think we need to think in 2 ways. One is moving forward, how are we going to address that? And we need to start thinking about new cohorts that include Hispanics, so that we can collect those data, particularly among the younger generations, so that we can really understand the impact of early life exposures. And the other way is thinking backwards. How can we creatively try to obtain some of the indicators that might be relevant? And I think Dr. Feckerman provided some examples. If we could get, measures of certain exposures from countries of origin and try to link that at a more regional level, at least it might give us some clues about what could be some of the key determinants that led to the cancer that we see right now. But I really think that we need to put the effort in the future and start thinking about collecting those data now among our Hispanic population, so that we're well positioned to link them to future cancer development moving forward.
Thank you. Anybody else on the panel want to comment, or anybody else who's in the greater audience?
Yeah, I have a few thoughts related to that. Thank you for asking that question, and giving us an opportunity to elaborate. As both Laura and I think, emphasize the importance of life course approaches. I think it's incredibly challenging, and I'm going to say again, I think we need better approaches and better methods. That said, I think there's certainly been improvement in terms of movements in this area. The SEER program as a whole has been trying to ascertain residential history through linkage to existing records. And I think there's a lot of promise in that. I think there's a lot more validation and methodologic sort of considerations that need to go into that, and would be great topics for various folks to take on and research. But I think there's a lot of promise in that approach. Certainly, it's not going to capture residential history among prior to coming to the US. So I think that migrant studies are a great way to really kind of try to address exposures that occur prior to immigration. Of course, there's a traditional way of just asking. If you have the opportunity to conduct surveys to ask participants about their perceptions and what they recall regarding their exposures. And then finally, I think that we need further development in terms of biomarker research to try to capture the cumulative exposures over the lifetime.
And let me add, I kind of try to present with a, futuristic, optimistic vision of how we can understand the effect of early exposures on cancer in Hispanics. But also there is something that I don't think we have done, and this requires the international collaborations just to know what's out there and to learn about accessing the right resources. But there's census data and there's surveys data in Latin American countries. There's a lot of information about exposures, diet, similar to NHANES in the US. There's surveys that can be linked, that could be linked to people if people in the US remember, for example, the zip code where they live in Mexico or their zip code in Argentina. And so it's challenging. It's not gonna be easy, but I think there are opportunities at least to start today. And then also think about the future, how we want to do things today to have that data in the future for the next generation of people that develop cancer. And those are two different things.
Thank you for that. I see that Albert Farias has his hand up.
Yes, thank you so much for these presentations. I think all of the speakers have poignantly showed us the heterogeneity and cancer incidence and mortality among Hispanics. And when we think about in the context of adding variables to enhance research in Hispanics, adding variables that have to do with the environment and the life course approach is important to get at disparities in incidence. However, I think that more research is needed to expand our understanding of what's contributing to disparities in mortality. For instance, once someone gets diagnosed with cancer, receiving evidence-based treatment is going to be so important. And the NIMHD framework on health disparities has that entire context on the healthcare delivery system. And some of my own work has pointed that Hispanics are less likely to receive evidence-based cancer treatment, even for early stage breast cancer. And so thinking about the healthcare delivery system and its contribution to disparities in cancer mortality among Hispanics is going to be really, really important. And I'm wondering, there's the SEER CAPS data set at NCI, which captures information on patient experiences with care and general health status, mental health status, and some health behaviors as well that's linked to the SEER data set. And, we've been identifying some disparities in Hispanics in some of these ratings. And I'm just wondering what your guys' thoughts were on heading in that direction and expanding upon the healthcare delivery system and its contribution to disparities.
Thank you. Does anybody on the panel or others want to answer?
Yeah, thank you for that very important aspect of trying to understand the clinical outcomes of patients with cancer. And it is clear we and others have examined all the different delays and not only delays but also not receiving the standard of care. And unfortunately, there's a very strong correlation between your education, your socioeconomical status, even your ancestry, like Laura was showing, in the people in Puerto Rico, where we see that individuals receive not the standard of care or the best care. Not only there are delays, but they're also not the best surgeons, not the best hospitals. So one of the things that the NCI and the cancer centers have done, it's trying to standardize, right, clinical trials access, which follow NCCN guidelines, which follow the best standard treatments, and eliminate the barriers that we all see among the different minorities, including our minority. So I agree 100% that healthcare delivery, it's an area that needs to continue to be explored, that there needs to be better mechanisms whereby health policy really intervenes. So research is key, and it needs to be included to allow us to, guide health policy. I see it every day. Differences, even in the same, neighborhood, how the same patient receives, superior treatment if he or she goes to the wrong hospital, or if he or she has the wrong insurance. I mean, we know that. So, very important point.
But let me add that part of how we think about epidemiology in this group is how we disaggregate, going back to the whole theme of not all Hispanic Latinos receive subpar care. Certain subgroups have a set of social determinants of health factors that contribute to the fact that they will have difficulties to access good care due to distance issues, due to language barriers, due to socioeconomic status. So I think that that work is kind of a different realm. Almost is not so much the epidemiology, but more the outreach, education, and development of policies and resources that resolve this major issue, here in the US and in Latin America, because this, again, it's the same story everywhere. People who are poor, people who are far away from high quality cancer centers, they do worse, they don't get the same treatment, and they die more.
Okay. Anybody else want to comment on this before we move to the next question?
Yeah, along those lines, I think we also see it here in the United States along the border as well, particularly for undocumented populations in South Texas, for example, that don't have that high level of care for cancer care. And if they're undocumented, then trying to get to Houston, for example, is very, very difficult.
Yeah, I shudder to think about how to capture exposures among persons in the migration process, particularly individuals who can't cross a border when they would choose to and are held either in the US or in another country, and trying to characterize those in terms of potential exposures. But that's another issue for sure. So there is a question in the chat about nativity being very hard to obtain, often not being asked at health facilities, and pointing out that there are many reasons that that Latinos might not choose to answer that question. And so the question is, are there any thoughts on how we could improve the collection of country of origin?
This is Scarlett. So I put in a response to that question. I think that's an excellent question. And I actually tend to think, and maybe I'm blissfully naive on this point, but I've seen research suggesting that as those of us sitting in the seats of administering surveys, or in particular healthcare providers and admission clerks who are in the front line of collecting these data from patients, that there is more of a reluctance to collect these types of sensitive information coming from the part of the collector than from the part of the person who's being asked. We've seen this research for race, ethnicity, for sexual and gender minority status. And so in California, we actually, public hospitals are required to, as part of a reimbursement, Medicare, I think it's Medi-Cal reimbursement, are required to collect gender identification and sexual orientation data that's tied to reimbursement. And in fact, if you see the data, the rates of collection and completeness have gone way up, suggesting that it's possible to do it if you just do it. And so I think that it's possible. I think that we have found in cancer registry data that information is missing is because that healthcare facilities simply aren't collecting it. And we do know from those that their rates of completeness are incredibly high.
Okay, thank you.
I do want to add though, that this is specific to birthplace and nativity information. I think most would agree that it's not appropriate to collect documentation status. You likely would get a lot of angry responses and misclassification and no response if you try to collect that information. And we don't collect that in any of our settings.
So I've been responding to some of the questions in the chat and providing a link to the Phoenix Toolkit. There's some discussion of surveys and sort of limitations of those as well. But back to the question on how you can get more granular in terms of origins. I think some of the questions, I don't know the answer. I think there's definitely a feeling that you're trying to get the most accuracy in terms of what population somebody comes from. And that's the number one question I get all the time. It's okay, well, if race ethnicity are so fuzzy, let's just use genetic ancestry and infer everybody and figure out what's the ground truth of where they really come from and what's their real population of origin. I think it's important to recognize that even the concept of a population is not really well defined. You can define a population geographically, geopolitically, racially, identity-wise, right? Or population of cases. So it's a really ambiguous term. And I think when we try to put people into singular categorical boxes, even as something like a population, we are making a mistake because ancestrally, most populations have mixed and mingled over all since modern humans evolved, right? So this notion that we should just put someone in one population category and use that is, I think it's problematic conceptually, but it's useful, right, for epidemiology. So the question is, how do you balance, right, the utility versus the precision or lack thereof? So I think, one thing that I've seen that's done well in some recent surveys and pilots is to ask about languages spoken in the home and countries of origins of the of grandparents, maternal and paternal grandparents. And then also, and genetic counselors do this actually in their surveys. They ask, do you know where your grandparents were from, or for your grandparents? And so I think that's been sort of clinically proven to help guide decision-making in the clinical context about what ancestry somebody might have and what genetic tests might be of relevance for them. But I think it's important not to stay so focused on which category can we put someone in and are we doing this correctly, but think about how we might go beyond this sort of categorical framing in our research to think about how we might look at more granular factors that are potentially causal, right? So social determinants of health in the Phoenix Toolkit could be a start where we think about what are the actual things that are contributing to disparities mechanistically, as opposed to using something like race or ethnicity, which is a proxy, or ancestry, which is again still a proxy in some cases when you're not seeing a direct relation to the genetics on an ancestral haplotype.
I would personally tend to agree with you. The problem is none of us controls who collects the data in individual institutions. And, we don't, you could have a focused study that collected better data, but trying to do things on a population-wide basis, it gets very tricky because there are lots of surveys, there are lots of hospitals collecting data, and while there's some consistency, the purposes for which those are collected are often not congruent with the needs of researchers. And I mean, I think it might be reasonable to throw out all final categorizations of individuals, but that's not realistic. That won't happen. You know, epidemiologists are opportunists. They take advantage of data, of natural experiments, of other groups collecting data that then they use for their own purposes. And so I don't think it's, well, I agree with you 100%. I think it's not quite as realistic as we would wish it to be.
Oh, absolutely. And I don't want to give the impression that I'm saying we throw out the categories. They're very important for longitudinal data and historical data collection, and the OMB categories as they stand are informative for measuring the experience of racism, right? That's what race is really useful for, is measuring the effects of racism. So I think that's something that I just wanted to emphasize. That I'm not saying we throw out the categories, but that we really think carefully about why we're using them, and really just placing them in our causal pathways to make sure that there's a good logic behind where they go in the model and for what purposes. So if we're looking for something like genetic background, you could ask an open-ended question, and we could push as a field for everyone to ask the question, where do you know that you have ancestors from? Or where, you know, do you know where your 4 grandparents are from? And if so, what countries or regions of the world are they? And just allow people to sort of have at it. And then we can use natural language processing later to kind of parse that out and figure out what are the trends that we haven't thought of to create a box for, or create a category for. You might learn something from doing that. So I think that's really more what the point I'm trying to make, is that we can do both. We can use the categories when they're useful, and then we can get more granular, and that could be potentially more informative.
What I think it's really important is to have specific questions targeted to, you know, we're trying to understand what causes, you know, what are the factors that are linked to cancer, for example, and to higher risk, to then do prevention, right? Like in many cases, what we want to do is change whatever increases risk and decrease the incidence. So if the level of disaggregation of what we want to ask, it has to be linked to our actions in the future to decrease risk. For one like obvious thing is when you're looking at incidence or trying to understand if diet affects cancers, to then modify it. If you group everyone in one big category, but we know that half of the, you know, Argentinians are higher socioeconomic status and education, and that's linked to, you know, exposure to fast food. Like, why are we gonna pile everyone together when we then are not gonna have the intervention targeted to the Argentinian population because they come from a more educated background in the US? It, you know, partly linked to the fact that it's very expensive to travel from there to here, you know, whatever the reasons, like that's not a good, that's gonna just change your results and give you something that is not the best estimate for the population that you want to target for prevention. So I think disaggregating has to do with that. Identify who we're targeting, so then we can prepare materials that are meaningful for that group. Use language that is meaningful for that group. We address the barriers specific for that group if there's such as, you know, if we can identify like a group that has the same needs.
Well, with that, thank you very much for those comments. And with those comments, we've come to the end of our time, I think, for yes, for this break. And so I will turn it back to.
We actually have 10 more minutes.
Oh, okay. All right. Then I'm wrong.
10, 15 more minutes.
All right. Thank
Mariana
you.
wanted to say something.
Yeah,
Okay.
so I just wanted to follow up on Laura's comment, because I think from our perspective as researchers and epidemiologists, right, and we're data greedy, we want to collect as much data as we can, right, so that we can look at things in different ways. And I think we should do that, and we should explore creative ways of doing that. But we also need to think on what we communicate to the participants in terms of why we're collecting those data. And I think that's an important point, because I have found in my own studies that with some Hispanic participants, reluctance or misunderstanding as to why we're collecting certain data. For example, for many studies, we are forced to collect race and ethnicity, right? And for many Hispanics, they don't think in that way. They don't think of those two things as separate things. They think, well, I'm Hispanic. So I had the situation of asking prospective participants in clinical trials or other studies, you know, what's your ethnicity? Hispanic, what's your race? I'm Hispanic. And they refuse to provide a race because they think they're Hispanic. And they don't understand this artificial distinction that we have created in our research that, as you know, Alice explained, comes from a history of the government and other, you know, objectives of the ethnicity and the race. This might not be obvious to a study participant or somebody in the community that we're trying to engage in our research. So I think we need to think of ways that we can, through our outreach efforts, perhaps, and through materials that we develop, to share our intention of what we're going to use that information for, so that what they provide to us, so that they feel comfortable providing that, but also that what they provide, reflects where they're coming from, because I think there's a lot of misunderstanding and a lot of fear as to how that information is going to be used. So I think that we should not, in our effort of collecting more and more data, we shouldn't lose sight of what perception we're giving to the participants as to how those data are going to be used. And maybe we need to share more why those data are important to us and how we're going to use it, and why it's important that they give that information to us.
I would agree with that. Are there other comments about it? Okay. Does anybody else in the among the listeners or among the panel members have a question they would like to bring up now? Yes, Amelie.
Hi, thank you, and thank you for just a wonderful panel. You all were wonderful. I wanted to ask Dr. Saenz, in terms of, for the first time, we might have a Latino to lead the U.S. Census Bureau. He's not been confirmed yet, but we're all thinking very positive. What would be the first challenge that you would give to Mr. Santos if he was, to be the bureau chief for the census?
Yeah, I'm very pleased that that Rob has been nominated, and it looks like he's getting close to being confirmed. I think that the major challenges, I think the race issue continues to be a major, and we saw tremendous changes that took place, particularly because the Census Bureau provided greater degrees of option and categorizing people. So we see the decline in white Latinos who classified themselves as white, and increases in those categorizing themselves as other, and then the as well as the multiracial categories. Now, one of the things that is also very, very important, because it gets into the world of politics and representation, is that if we do go into becoming a racial category, as the Office of Management and Budget had been trying to see about that, or the Census Bureau was trying to explore that. Right now, we have the categorization in terms of the percentage of the population, 19%, for example, that are Latino. But if we become a race, what happens? Because now those individuals, then that we might be in the multiracial category, or so it becomes a little bit more complicated. So we need to also think about those kind of challenges as well.
Thank you. There's somebody's name that I'm going to mispronounce, so please correct me. Dr. Ajayi. You have your hand up?
Okay. Thank you very much. Can you hear me?
Yes.
Okay. Please, I would just like to ask, I'm a researcher from Nigeria. I'm interested in studying the biology of cancer disparity, especially racial disparity. And I noticed we don't have much more in racial disparities of colorectal cancer. So I have access to samples in Nigeria, I have samples from Nigerian cancer patients. I don't know if it's possible to collaborate and get sample from other ethnic group abroad.
Are there researchers on the, I mean, certainly the answer to that, of course, is yes, there are possibilities. Are there researchers on the call or folks from the NIH like to make a comment about that?
Okay.
Yeah, I think, yeah, I just would say that that could be something that you send an email to discuss possibilities to people in the panel, or maybe NCI can generate some platform for exchanging, for collaboration, between studies, people who attended this workshop. I think something like that.
So your audio broke out there for a little bit, so we didn't hear all of your question or your comment, but it sounds like you have data from Nigeria on colorectal cancer. And if you do in fact have genetic data from a clinical setting, I'd be happy to connect you with the folks at ClinGen, since we are definitely trying to diversify the participants in our expert panels and working groups, and sort of look at how diseases are impacting global populations as well. So feel free to reach out and I can connect you to folks in ClinGen.
One last question then from Dr. Espinosa.
Yes. Hello. Thanks for the talk. It's really illustrative. Thanks to all the panel. Well, I guess what I wanted to ask, it was a follow-up on the question of Dr. Ramirez, and I see that also Dr. Carvajal mentioned this in the comment, is that there's this question of race in Latin America that has its own kind of own cultural development or historical development, separate from the United States, and that it's now I'm seeing this impact in the with immigrant populations, and what I mean is that since European invasion, there's been a negation of being indigenous and being Black, and that has led to a lot of the foundational myths of a lot of countries with indigenous majorities, where like we're a mixed country and everything is happiness. And I've noticed that now, particularly in the countries of origin, in Mexico and Peru, Bolivia, there's assertion of, oh, no, I'm indigenous, my main heritage is indigenous, and this is who I am. And I've seen this also reflected in the United States to a lesser degree, but I have seen it reflected particularly in the areas of the Southwest, Texas to California. So if we're going to include Hispanic or Latino or Latinx or whatever we're going to use as a race, then we should also expect that a lot of, or especially a younger generation, is going to start identifying themselves as indigenous instead of Latino, instead of Hispanic. And from my point of view, I think that's accurate. So I guess my question is, how would you tackle that? Because we usually in the United States, we separate the indigenous just for Native American indigenous people. So now as more what we would consider, Mexican or Hispanic people will start identifying as indigenous, how would you start managing this change in self-denomination?
Go ahead and answer that.
and that was one of the categories of the racial categories that did increase right after multiracial other, and then the third fastest growing was the Native American population, and that reflects, I think, to a certain extent, the greater immigration of indigenous people to the United States, as well as particularly maybe among the younger segments of the population with greater degrees of consciousness and identifying as indigenous.
I think still these categories are complicated for immigrants. I remember when I arrived in the US, I was like, what? You know, I have to, who am I? I was very confused by being asked about race, for example. And then I was like, am I white? I never felt white. What does it mean? You know, so I think things are gonna change because the people who come in are changing. We are talking more about certain things, so people might be learning. And I guess at the end, what we capture with the census category is a rough estimate of you know, who are the Hispanic Latinos, because I think there's still many of us who might just not mark the box that people expect us to mark. And Native American, I mean, that's the racial categories are confusing for Latinos. With Indigenous American ancestry, it will depend how that ancestry is talked about in their country of origin or in their community, and they might not recognize it as the same ancestry, you know, like, oh, we mean this, we are the original peoples of the Americas, you know, and we use as scientists all these terminologies: Native American, Indigenous American, Amerindian. I mean, you see papers with switching terminology. It's like we don't even agree on how to talk about this. And then we ask people to self-identify using categories that we're confused about.
Okay, we'll take one more answer. Dr. Carvajal Carmona, you have your hand up.
Yes, I think, you know, the issue with there is something that we need to acknowledge is that there is racism within Latino community. Afro-Latinos have been historically discriminated in Latin America. And indigenous people of indigenous ancestry have been also discriminated in Latin America. Many people in our communities, many people in our families don't fully accept that we have African or indigenous blood. So, you know, this is a sensitive aspect for Latinos here too. So it's not as easy for someone to accept this. Another aspect of you know, that we see here is here in California, Central Valley, 1 in 10 farm workers don't speak Spanish, and they are Latinos, Mexicanos, indigenous speakers, Triqui, Zapoteco, Mixteco. We have a lot of people who rarely, you know, is in the radar of organizations like the ones that we are attending today. And I think, you know, this issue with race is very complex. We have major issues to accept this in Latin America. It's a legacy of the, you know, Spanish and Portuguese colonial times, because when they arrived, whites were at the top and the rest of us were at the bottom, right? So there were multiple definitions at the time: mestizo, castizo, sambo. All these definitions were highly discriminatory terms that don't allow us to accept or actual genetic or ancestry. So it is very hard for Latinos to understand that. The other thing is, when we come to this country, we don't know who we are. I came to this country 10 years ago. I wasn't sure if I should call myself Hispanic, Latino, Colombiano. Those are things that are artificial, at least for immigrants like me.
Okay.
Yeah, I think this is a really important point, and this discussion of indigenous from Latin America versus Native American or American Indian Alaska Native. There are hundreds more tribes and tribal bands and groups among American Indian Alaska Natives than are federally recognized. So, and many in California that are recognized by the state but aren't recognized by the federal government. And in most surveys that ask about American Indian Alaska Native identity, explicitly say federally recognized tribes. So even within the American Indian Alaska Native communities in the United States, folks feel disenfranchised by these categories. As I learned through working with the Pathways to American Indian Alaska Native Wellness liaison from Stanford and the Community Action Board, it's been really enlightening to hear these, hear their concerns, and also from colleagues from Latin America who have indigenous ancestry and talk about not being Native American. But this is the rub. When we use genetic data, we don't have reference panels, genomic reference panels for American Indian Alaska Native populations. So when genetic ancestry companies or researchers are doing inferences of ancestry based on genotype data for the Native American category, they're using Latin American reference panels from Peru and a few different labs in Mexico. So they're actually mapping American samples from Hispanic Latino populations to ancestry human population reference panels collected in Latin American populations. And again, that's just in a few locations that are meant to represent an entire category or an entire continent of individuals, and then reporting ancestry or Native American ancestry based on matching with Latin American reference panels, indigenous sometimes, or obviously there's a huge mixture there. So there's a lot of confusion here and this discussion around sort of ancestry, race, ethnicity, and that's the point I hope to drive home, is that when we talk about a ground truth of population identity, even when you talk about genetic ancestry, we don't have the answers. The DNA doesn't have the answers. So if something's an identity, that's how somebody personally identifies. But if it's genetic, we can look at the genotype and actually know, with precision and accuracy what nucleotide somebody has at a particular spot in the genome. But what that means for our identities or our ancestry or even health and disease is really difficult to tease apart.
Thank you for that comment, very thoughtful. And thank you everybody for the comments that you've shared during the discussion. And I appreciate the people who've questioned, the people who've answered, and for the organizers